Hello. This segment is called Caring for the Person with Alzheimer's Disease. I'm Gail Hirsch on faculty here at the HGEC. The following presentation is for the use of certified nursing assistants and caregivers, and the following slides are not intended for CE credits. The Houston Geriatric Education Center is funded by HRSA, and so therefore we're able to provide these kinds of learning sessions. The objectives today are successful students will be able to first define dementia, will describe Alzheimer's disease and the disease progression. Then we'll talk about critical skills that are needed to care for people with Alzheimer's disease and how do you communicate with people who have this diagnosis. And finally, discuss some interventions that you can use for dealing with residents who may have difficult behaviors. As you can see by this graph, the projected prevalence of Alzheimer's disease is on the increase, and that goes along with the greater numbers of older adults of that segment of our population growing, especially now with the baby boomer population. And so it is definitely going to be on the increase. Therefore, there'll be more people needing care. What is the definition of dementia? It is a progressive global deterioration of cognitive ability in multiple domains, including memory, that's the first one, and at least one of the following: orientation to time, place, and/or person, learning skills, language comprehension, and judgment. Defining dementia. It's most important that you understand that dementia is not a normal part of aging. It is a disease that is progressive, degenerative. It depends on if it's young onset, after 65. Onset varies. And the other important factor is that is irreversible. There are different kinds of dementia. One of the potential areas that you might recognize, and even in your own family members or friends, is a mild cognitive impairment. And those symptoms are really vague and may include memory loss and language disturbance, attention deficits, and deterioration in visual, spatial skills. And it's difficult to say if that will lead automatically to dementia, as there are varieties of mild cognitive impairment that may not. The main one that you'll see is Alzheimer's disease. I'll explain what that is caused by in a few minutes. And then there's vascular dementia, frontotemporal dementia, Lewy body dementia, and Parkinson's. The basics of Alzheimer's disease: we've just said it's progressive, it's degenerative, it's irreversible, and there is no cure. And it is the most common type of dementia with older adults. It is caused by tangled nerve fibers and protein deposits that form in the brain and eventually cause dementia. However, the cause of these fibers and proteins occurring is unknown, and eventually leads to functional dependency. The progression. The symptoms appear gradually. They don't just come on all of a sudden, let's say after a car accident. They appear gradually. The symptoms do worsen with progression. Typically it begins with memory loss, especially with driving. That's usually one of the first signs that you'll see. People get lost, and even in familiar surroundings. Or they can't balance their checkbook. Those are usually one of the first signs of memory loss, really having to do with your instrumental activities of daily living. People with dementia may become disoriented later. They may experience mood and behavior changes. Communication becomes difficult. And eventually, in the very late stages, They lose all ability to care for oneself. You'll see many ways of describing the stages or phases of dementia. This is one way that the FAST, Functional Assessment Staging, provides. Stage 1 being normal, no functional decline. Stage 2, normal older adult, personal awareness maybe of some functional decline, like, gee, I can't find my keys, or where did I park the car? But then it comes back and it's okay. Early dementia, stage 3, then you begin to notice deficits in demanding job situations. Driving might be an instance. Stage 4, then you get into the mild stage, requires assistance in complicated tasks such as finances, planning, those kinds of things. And finally, 5 and 6 stage, moderate to moderately severe, requiring progressively more assistance with their basic activities of daily living. And finally, in stage 7, speech ability is declined, progressive loss of the ability to walk, sit up, move about. It is important to recognize where the person is along the stages of progression, so then you know how to intervene. Now we're going to talk a little bit about the skills needed to care for people with dementia. First, don't take things personally. They're not attacking you. They're not criticizing you. Something has happened for them to say or act the way they do, and it is not probably anything that you have done or not done. An important part of being a formal caregiver, like a CNA, is being empathetic, showing empathy, not sympathy, but empathy, a caring attitude toward your client, and also being aware of the symptoms and behaviors that you might see so that you do know how to approach them. I think the important part here is to be aware of what could happen and anticipate behaviors or symptoms so you know what to do with them. Another set of skills, teamwork is critical. You're not going to be working alone. You're going to be working with other nurses, the physician, psychologist, the activity department staff, perhaps the occupational therapist, the physical therapist. There's a team, and that team makes decisions about the approach with your patients. You may experience caregiver stress, and dealing with these kinds of patients is not easy. And so when you do feel that coming on, you need to recognize it and seek help for yourself. Also, family members need to be taught and reminded about the disease and its progression. It's all new to them, and they too are going through some stressful times, seeing a loved one being affected by this devastating disease. Again, the plan of care is key to helping people, and that's all part of your teamwork, making a plan of care that everybody works from. Communication strategies. These are some general strategies that you can use with patients who have dementia. First of all, be calm. If you get excited, you're more likely to make the patient more excited. So be calm in your approach. Decrease any kind of distraction. Work with the person in their room. Make sure it's quiet, that there are no extraneous sounds or other people in the room. Keeping them focused is very important. Use simple words and short sentences. Watch your body language. Your body language says a lot about what you're communicating to the person. So you want to be careful how your body language is being seen by the other person. Communication strategies for people who have memory loss. It's important that you repeat what you're saying, but use the same words if instruction or questions need to be repeated. Sometimes the person may not understand a word, in which case you can try to glean information by asking related questions about what they're doing or how they did do it. Repetition can be soothing for some with dementia, and many with AD will repeat words, phrases, questions, and actions. This is called perseveration. If a person perseverates, the caregiver should answer their questions using the same words or very similar words each time until they stop. It is not necessary really to stop the patient. Again, keep things simple. Many times people with dementia have trouble finding words and names. So you can suggest a word that sounds correct. If this upsets the person, try to learn from that and perhaps not use that word again or use another approach. But don't correct the person who's using an incorrect word. Many times you can tell what they're communicating by their expression on their face and the person's body language, or the way they're pointing at something. Smiling, touching, hugging can help show care and concern, but the thing to remember is to make sure your patient is open to being touched. For some, this can frighten the person and make the situation worse. People may have difficulty understanding basic instructions or questions. What do you do then? Ask the person to repeat those words and allow time to answer. Again, use short words and sentences. Note the times when your communication is effective and use those same methods. The same method may not work for every patient, so you may need to individualize your methods. Again, watch for that nonverbal communication, especially as the speech declines. Use visual communications, signs, pictures, gestures, written words. You could come up with a picture or communication card. Many times a speech therapist might be able to help you with that. Combine verbal and nonverbal communication so they get multiple input, but they're expressing the same message. When the person wants to speak but can't, so encourage the person to point or gesture or act it out. Even you might be able to act it out knowing what you think they're wanting to tell you and see if it's similar. If the person is obviously upset but cannot explain why, then offer comfort with a hug or smile, or better yet, even distract the person. We're going to talk about some strategies for distracting the patient. Remember, verbal communication may be frustrating for the person. Sometimes just sitting with the person, listening to what they're trying to say, is a better approach. What's very important is to create a facilitative environment. Structure the environment so the person with dementia, first of all, is safe, that they're not going to be subject to falling or endangering themselves with sharp objects of any kind. So structuring the environment is critical. Provide some easy interpretable cues to know where they are. So again, eliminate hazards. Make the toilet visible from their bedroom so they know that's where they need to go to urinate or defecate. Have lighting that reduces glare. Again, eliminate those distracting noises. And music from their generation has been shown to reduce agitation and aggression and mood disturbances during eating, bathing, and dressing. So playing some of those old tunes is a really very appropriate strategy. If they are dependent on so many of their ADLs, It's important to have them do whatever they can and to facilitate that skill, no matter how low or little it might be, and no matter how small. So, for instance, lay out the clothes in the order they need to be put on and point to them. Most of the patients will still have their motor skills, their ability to carry out motor acts, and so they can easily put on the clothes and take them off, but they may not do it in the sequence in which it needs to be done. So laying out the clothes in order how they're to be put on is helpful. Provide written reminders, and I would say more than written reminders is pictures. Having pictures of the sequence. Providing finger foods so that they can at least feed themselves. That is the last skill that remains for people with dementia. At least placing food into their mouth. And so if we can provide that little bit of skill, that makes them feel that much better. Maintaining safety. If the person insists on doing something harmful, unsafe, or not allowed, the caregiver should try and refrain from using the word don't, and instead to redirect the patient. If the person begins to hallucinate or becomes paranoid or accusing, the caregiver should, again, here we go, try not to take it personally. Try to redirect their behavior or ignore it if it's not too harmful at all for themselves. These types of behaviors tend to pass quickly due to the short attention span. But you need to monitor these behaviors in case they do persist, and I would strongly suggest discussing these behaviors with your team. Depression, loneliness, homesickness, all can occur. If the person seems depressed or lonely, you should repeatedly ask to go home. The caregiver actually, I would suggest seeking help from your team as to the approach you should use, and also talking with a physician and seeing maybe an antidepressant might be helpful or some type of medication. But the most important thing, I believe, is to provide activities that promote positive feelings. And such activities as gardens, having to go out in the garden, play with the soil, bird feeders, picture albums, familiar books. Physical activities are wonderful. Dancing, walking. Food is a social activity with much impact. Reminiscing, using cues that click in to their old memories. And spiritual activities like prayer groups, support groups, religious services. It's really remarkable how they'll still be able to say those prayers even though they really can't do anything for themselves. And of course, if they're stage dependent, you still want to provide some kind of stimulation and also to watch for bed sores, any kind. You do not really want them to stay in bed, but to have them up in a wheelchair or a chair that's safe so that they can still look around and see what's going on. I'd like to talk a little bit about meaningful activities. They matter to all people, and some of the categories that you can think about in these activities has to do with work. It's not so much money, but the kind of work they used to do, so talking about the work that they used to do, their occupations. Leisure, using leisure activities to help them in remembering what they used to do. And maybe there might be some semblance of that leisure activity that could be done again. Self-care, taking care of their hair, maybe taking care of combing their hair or brushing their teeth. Simple kinds of things that make them feel better about themselves. And last, and one that's very important that we don't always think about, is rest and restoration. It's important that rest includes sleep, but also time taken alone or with others. It really helps a person to recharge or restore themselves, just like it would for you or me. And the other thing that's important is the music that was mentioned before. Using music at least twice a day for both the caregivers and those living with dementia. It's a very powerful resource. Find the music they like, and it can help them to relax, to calm or change a mood, and it really gives them a sense of peace, joy, remembrance, and positive feelings for everyone. We've talked about some of these a little bit already. Communication strategies in terms of loss of verbal skills. Again, use your nonverbal skills. Use body language to express what you want to convey and utilize what they're trying to convey to you. If they are willing, touching, smiling, and laughter will be understood much longer than words. And remember that they don't understand any more than they can express, and so you have to be careful about that. But never talk to someone with dementia as if they are not there, or if they were a child. You don't want to talk down to them. If they're in the presence, you should recognize them. There are common behaviors that the team needs to address, and these include agitation, catastrophic reactions, violent behavior, pacing and wandering, hallucinations and delusions, depression, suspicion, inappropriate social behavior and sexual behavior, and sleep disturbances. Quite a list. Not all patients with dementia will have these behaviors. Some will have more than others, and we need to be on the lookout and be aware of the possibilities. Interventions for catastrophic reactions. I think what's important here is be aware of the triggers. What's causing, anticipate what you think might be happening. So what's causing this to happen? It could be they're just tired, or there's been a change in their routine, environment, or caregiver, or they're overly stimulated by the environment. They have difficult choices or tasks that they can't handle. They have physical pain, hunger, and the need to toilet themselves. So you need to be aware of these triggers and rule them out to make sure that it's not one of those that could be handled. Caregiver response is the same as for agitation, and reactions are often their way to communicate something is wrong. So usually this is communicating to you that something is wrong. Violent behavior. Block blows, but never hit back. And that's so important. Just step away from the person and call for help. Don't leave the patient alone. And remove as many of those triggers as you can, or at least be aware of them. And then again, use the same technique to calm the person as used for agitation. And that could be your silent approach with them, music, or redirecting them with a favorite activity. Intervention, pacing, and wandering, and these can be caused by some of the same kinds of things that might cause violent behavior or catastrophic reactions. Restlessness, hunger, they're disoriented, they really don't know where their room is, they don't know where they are, the need to toilet themselves, even constipation, certainly pain, and forgetting how or where to sit down, something as simple as that. And their need for exercise, to move about in a positive way. So the interventions for pacing and wandering. They may try to elope or leave a facility or home unsupervised and unnoticed. We have to be very careful of that, and most places now have safeguards in place for that. But if a caregiver believes a person with dementia has eloped, the supervisor must be immediately notified and often find that person where they have been last seen. Keeping a current photo available to identify the person is very helpful. Using ID cards or bracelets, labeling clothing. These are all preventative ways so that you'll know the person someone can recognize the person who has the dementia. Interventions for hallucinations or delusions. First of all, ignore the harmless ones. You can't deal with them all. But reassuring the person who seems agitated or worried that they are having them. Don't argue with the person who is imagining things. Those feelings are real to them. And the caregiver should not tell a person that they see or hear those person's hallucinations. That's just going to reinforce it. Really, the best thing is to redirect to another thought or activity. At the same time, being calm and reassuring the person that you are there to help. Interventions for depression. Interventions for depression are usually, as we've talked about before, are handled through, first of all, recognizing it and then getting medical help through the physician or the nurse to see what's causing the depression. Many times they're just feeling sad and need to be acknowledge those feelings of sadness and then redirect them. Sometimes it requires medication, and so we need to be aware of when the person is showing those depressive symptoms. If they're perseverating or repeating phrasing, again, you try not to stop the person from perseverating. Answer the questions each time they're asked with the same words and the same response. That means you have to be patient with the person, of course, and that is what causes a lot of caregiver stress, losing that patience with the person. The other very important one is understanding where the behavior could be coming from. Is it from their confusion, disorientation? If we know where it's coming from, maybe we can solve the problem and make them feel less agitated and disoriented. It's possible they'll feel suspicious. It's possible that they are showing inappropriate social and sexual behaviors. One of the mistakes that providers make is to judge the behavior as challenging or problematic and then attempt to stop it before taking the time to notice what's really going on. And so, keep in mind, human behavior is almost always an attempt to communicate or meet a personal need. So remember that individuals are doing the best they can with their remaining cognitive or physical ability. They often are expressing what they like or don't like about an environment, or what providers are doing or not doing to them. So when this happens, it will require a pause or time out to observe and think through what might be happening behind the presenting behavior. Sometimes providers don't realize that they are the cause of the challenging behaviors because of approaches that don't work or lack of understanding about individuals' unique preferences. It is important to partner and work with a person when they are behaving in a way that surprises us. In order to be successful in changing behavior, it will be about how we respond to what is happening and what we choose to do that will make the difference. I think what's really important is that you use the team to help you make those decisions about what approach to use with the client. Sleep disturbances. That happens especially in the moderate to late stages. Some things that you could do for that is to set a routine with no lengthy naps, keep active during the day, and no heavy food after dinner. Those are simple kinds of things that really might help the person to sleep through the night. Setting a routine, no lengthy naps, keeping active during the day, and no heavy food after dinner. Here are some references from which the information on these PowerPoint came from, but also I'd like to mention the Gerontological Society on Aging has a book called Communicating with Older Adults, some really good information in there. And also Teepa Snow, she's an occupational therapist and has some wonderful videos, and strategies to use. If you're working as a team, you could easily view those videos and actually get to see some of these behaviors being played out and managed. Thank you for your time.